Members, you are welcome again to this session. Second Francis is my name. I'm your host today, and we are having Jerome taking us through. And at this time, calling upon him to start his session. Jerome Cosmas, you're welcome, please.
Thank you, Francis. I welcome you all to this session, which we anticipate will take an hour's duration. The topic today is laboratory diagnosis of Helicobacter pylori ulcers and the suspected possible twist in current diagnostics and management of Helicobacter pylori gastritis. I'm by the name Boga Jerome Cosmas, a master graduate with a bachelor's degree in medical laboratory science, that is 2017, and the lab manager, Kisubi Hospital Diagnostic Laboratory, which I represent today. We'll start right away with the introduction and the pathogenesis, just a brief history about Helicobacter pylori for all of us to understand what H. pylori really is. H. pylori is a gram-negative urea-utilizing organism found in the stomach and the duodenum, being the main causative agent of ulcers worldwide. It attaches to the stomach lining, producing cytotoxin A, which leads to formation of an ulcer, thus its colonization and manifestation. The biggest question today is, did you know that 50% of the world's population have H. pylori bacterium? And that out of 90% of people with ulcers have them infected with H. pylori? This is quite amusing and quite an alert that we need to come up so strongly and face this right now. So it is strongly related to diseases such as chronic active gastritis, peptic ulcer diseases, atrophic gastritis, MALT, and non-cardio gastric ulcer. Many individuals actually remain asymptomatic, with other infected individuals occasionally having episodes of belching, bloating, nausea, vomiting, abdominal discomfort, and then in severe cases, we have abdominal pain. Some actually go ahead and complain of back pain, chest pain, ENT issues, vomiting blood, passing dark stool, fatigue, anemia, low appetite, diarrhea, peptic ulcers, heartburn, and bad breath may also occur, just like we can see with that lady up there in that picture. H. pylori is highly contagious and can spread through poor sanitation and drinking contaminated water. But however, lifestyle has been noted to be another great contributor to the manifestation of this infection, such as in individuals that do smoke, alcoholics, depending on the types of foods that we eat, those that eat acids, juices, quenchers, sodas, and the rest of those, stress, time when meals are taken, to mention but a few. We'll briefly look at the current available diagnostics. I called it laboratory diagnosis, but some of them actually go a little out of laboratory, but it's still all under diagnosis of H. pylori. Several invasive and non-invasive diagnostic tests are available for the detection of H. pylori, and each test has its usefulness and limitations in different clinical situations, although none can be considered a gold standard in clinical practice. Several techniques have been developed to give more reliable results. Just like you can see below here, we have an endoscopy procedure, which is also one of the tests performed to diagnose H. pylori ulcers. We have the urea breath test, the UBT. We have the antibody stroke antigen test, and then we also have culture and sensitivity. There are many others that I have not mentioned, but we'll be seeing in the slides to come. We'll look at the invasive tests. We'll start with endoscopy. Conventional endoscopic examination is usually performed to diagnose H. pylori associated diseases, such as peptic ulcer diseases, that's the PUD, atrophic gastritis, MALT, and gastric cancer. Endoscopy is also an instrument routinely used to obtain specimens, usually gastric mucosa from biopsies, for further studies on other invasive tests, including the rapid urease test, histology, culture, and molecular methods. So the urease test we are looking at here is a little different from the urea breath test, just like we'll see later on. Histology. Histology is usually considered to be the gold standard in the direct detection of H. pylori infection, and is also the first method used for the detection of H. pylori. However, several factors influence the diagnostic accuracy of histology, such as site, size, and number of biopsies, staining methods, the PPIs, which are some of the drugs used in the management of H. pylori, the antibiotics used, and the experience of the examining pathologist. Then we'll go to the rapid urease tests for routine clinical practice. Rapid urease tests, the RIU, is the most useful invasive test for the diagnosis of H. pylori infection because it is inexpensive, rapid, easy to perform, highly specific, and widely available. Based on the activity of H. pylori urease enzyme, the presence of H. pylori in the biopsy specimen converts the urea test reagent to ammonia, leading to an increase in the pH and a color change on the pH monitor. Then we'll briefly look at culture and sensitivity. Culturing of H. pylori from gastric biopsy specimens is a highly specific but less sensitive method. In general, culturing has almost 100% specificity, but the sensitivity of culture shows significant variation between 85% to 95%. Because of the delicate and fastidious nature of H. pylori, the cultivation in vitro requires particular transport medium, growth medium, and incubation environment. Last among the invasive tests, we'll look at the PCR, which is the polymerase chain reaction test. The PCR has been used extensively for the diagnosis of H. pylori from gastric biopsy specimens, saliva, stool, gastric juice, and variable specimens. PCR provides excellent sensitivity and specificity, greater than 95% as compared with other conventional tests, and has more accurate results of detecting H. pylori in patients with bleeding. Just like we'll see in the next slides, some of these tests are actually affected by the bleeding, since we all well know that as the ulcers go on progressing, we have bleeding going on. We'll briefly look at the non-invasive tests. Several attempts have been made to avoid endoscopic diagnostic methods for several reasons. First and foremost, endoscopy is an invasive procedure with discomfort and not suitable for patients with severe comorbidities or contraindications. Besides, cost of endoscopy and additional costs adding on endoscopy, such as disposable forceps and anesthesia, may be high. Last but not least, sampling bias is almost inevitably encountered in biopsy-based methods due to uneven distribution of H. pylori in the stomach. What we're trying to look at in this statement is that as we are picking up these biopsies, or as these biopsies are being picked up during the endoscopy procedure, it's really very hard to pick up a biopsy to be very sure that this is the biopsy containing the H. pylori bacterium. You might have an ulcer that is not infected. Chances are high that you might have one that is infected, but it doesn't leave out the chance that you might pick out one that is not infected. So we'll look at the antibody-based tests. These are mainly through serum, that is serum, plasma, and blood, whole blood. Numerous serological techniques or tests based on the detection of anti-H. pylori IgG antibody are widely available for H. pylori diagnosis. And EIA test is the most common and accurate technique among them. Serological tests have also frequently been used in screening for epidemiological studies because of their inexpensive, rapid, and acceptability to patients. So we'll find out that it's easier for a sample to be collected. You can do a needle stick, you can do a finger prick to collect this sample, and the results will be out within very few minutes. And this is one of the cheapest tests actually apparently available for H. pylori diagnosis. Next, we'll look at the UBT, which is the urea breath test, which is an interesting invention that has come up in Uganda so far, but it was already available abroad. The UBT has been used for almost 30 years and is still the most popular and accurate inexpensive test for diagnosis of H. pylori infection. By the urease activity of H. pylori, the carbon 13 or carbon 14 labeled urea is ingested by the patient and is hydrolyzed to labeled carbon dioxide in the stomach. Then the labeled carbon dioxide is absorbed in the blood and exhaled by breathing, in which the labeled carbon dioxide can be measured. So in this procedure, the patient is given a pill containing urea, but this urea actually contains carbon that has been dated or that has been labeled. So that labeled carbon is broken down or metabolized into carbon dioxide. So the carbon dioxide will be absorbed into the bloodstream and then will be exhaled. And this labeled carbon dioxide will then be measured. So a positive, if at all we have a positive labeled carbon dioxide test, that means we have a positive test for the H. pylori bacterium. If at all we do not have any of it labeled, then the test is negative. Then last but not least, we'll look at the stool antigen test. Stool antigen test is the other non-invasive method with good sensitivity and specificity. That is 94% and 97% respectively in global meta-analysis in the diagnosis of H. pylori infection. This method detects the presence of H. pylori antigen in stool samples. There are two types of stool antigen tests used for H. pylori detection. That is to say the enzyme immunoassay, the EIA, and the immunochromatography assay, the ICA-based methods, using either polyclonal antibodies or monoclonal antibodies. What is the current management of H. pylori worldwide? The recommended guideline for management of H. pylori, or the regimen available, is the treatment regimens currently available include omeprazole, amoxicillin, and clarithromycin. That is for 10 days. Then we have bismuth subsilicate, metronidazole, and tetracycline, the BMT, for 14 days. And then we have lansoprazole, amoxicillin, and clarithromycin, which has been approved for either 10 days or 14 days of treatment. In all these regimens, clarithromycin has been included as the first choice macrolide for treatment of H. pylori infection. And this has been widely adapted to, with several kits developed containing the triple therapy, which was intended to avoid any resistance emerging due to the worldwide spread of the infection, even in asymptomatic individuals. The reason for this presentation is to look at the emerging resistance to clarithromycin and the multi-drug resistant H. pylori strains. An increasing number of patients have been treated with the triple drug therapy. Some have improved while multiple others have not. Some show improvement for weeks and then symptoms reoccur. Many questions come into play, such as whether it's a reinfection, recrudescence, or resistance. Maybe to some of the non-medics that might be available on the platform, when we when we look at when we talk of reinfection, we are looking at a new infection. You've been treated and the treatment has been completely finished, but then you're acquiring a new infection of the organism. Then when we look at a recrudescence, we are mainly looking at maybe an organism or a disease or a situation that was not completely treated, then it is reoccurring. Then when we look at resistance, the organism is present in the body, but the drug being given to it cannot act on it, it cannot kill it. So those are the questions that come into play. These are all yet to be studied to establish the exact situation or condition in play. In our study so far, we are kind of trying to do a comparative study. In our study, we are using stool samples. In the study, we were trying to look at what they used were gastric biopsies for culture and sensitivity. So far, what we have, we've used Brucella blood agar, brain heart infusion blood agar, and urea agar. Out of 24 samples that were positive on stool antigen test, only one was intermediate to clarithromycin, while 22 samples were resistant, and one had no growth on culture. However, fluoroquinolone drugs, that is ciprofloxacin and levofloxacin, had better results with 5 sensitive, 1 intermediate, and 17 resistant on ciprofloxacin. Then we had 7 sensitive, 2 intermediate, and 14 resistant to levofloxacin. Then we had 5 sensitive, 2 intermediate, and 16 were resistant to doxycycline. I'll share a case scenario of a 9-year-old female attending pediatric clinic at our hospital who had history of treatment with the H.pylori kit 3 times with just a little improvement after treatment for 2 weeks and symptoms reoccurring later on. This was our first participant in the study whose sensitivity pattern was doxycycline sensitive and tetracycline sensitive. Clarithromycin and azithromycin were all resistant, as well as ciprofloxacin, levofloxacin, and amoxicillin. The patient was later on started on doxycycline, rabeprazole, and amoxicillin, and has since shown great improvement. Since then, we hope to review her and discuss our findings in the later presentations. Prospective management. What does this mean to the management of H. pylori gastritis or H. pylori ulcers? There is urgent need to revise management plans for H. pylori infection. There is also need to determine why H. pylori is no longer responding to clarithromycin. Is it a recrudescence? Is it because maybe the organism is being subjected to a less dose or a low dose of the antibiotic? Is it because of resistance? Is it because the organism has now become resistant that the drug can no longer work onto it? Or is it a reinfection? All these are the questions that we have right now that really need answers. There is need to combine 2 or more diagnostic techniques to completely come up with proper patient management and effective treatment. Just like we've seen it with TB, that after a patient has got a smear positive or smear negative result for TB, we still go ahead and do what we call a DST, the drug susceptibility testing, to find out if the drug we're giving this patient will work for this patient. So there is urgent need to incorporate culture and sensitivity in the management of Helicobacter pylori gastritis management, so to find the exact antibiotic of choice according to the sensitivity patterns, since all our participants showed different sensitivity patterns. What do these results mean to the current management of Helicobacter pylori gastritis? In our laboratory, serum H. pylori, that is the antibody test, was phased out, and we have resorted to the use of stool H. pylori, that is the antigen test. Our study also was used as a method validation process, providing us with a 95.83% accuracy of the Atron antigen stool antigen test manufactured by Atron Laboratories, that's in Canada. So we hope the findings in this study will effect the change in management of Helicobacter pylori gastritis. We hope that this study will be an eye-opener to all of us to appreciate the role of diagnostics in the eradication of antimicrobial resistance worldwide. We'll finally discuss the role of diagnostics in this situation. We hope that the main role of the laboratory in this course will be to provide the right result at the right time for the right patient, and that the clinician's role will be to receive these results in time, provide the right treatment to the right patient at the right time and for the rightful infection. We completely discourage self-medication, as this is one of the most contributing factors to antimicrobial resistance. Failure to contribute treatment or exposing the organisms to low doses of the drug are also some other factors leading to antimicrobial resistance. At the end of it all, we all have a role to play in stopping antimicrobial resistance. Not only H. pylori, but all other microbes or all other organisms. We've found out that of late we have so many resistant strains of macrolides, that is to say azithromycin and clarithromycin, but this is because these drugs have got a very low pill burden and people feel comfortable using them over and over again for upper respiratory tract infections, for UTIs, and of late we are facing resistance to some of these organisms. So we need to all come up, join hands, join this fight to fight antimicrobial resistance. Maybe just to inform you about the study we have ongoing in the lab. The first phase of the study is to choose the sample, and the sample we've chosen this time round is stool, because we found out H. pylori cultures are really hard to perform in conventional laboratory testing. And the testing that has been done, that has been approved according to the studies we've looked at, has been on gastric samples. So in our study, we hope in phase 2, we shall be able to come up with comparative results to compare with the gold standard, which is the gastric biopsies. And then later on, we hope we can compare it with other tests such as PCR. So we can make this as easy as possible to be performed in any laboratory before initiation of treatment. Otherwise, I want to thank you very much for having attended this session. And right now we'll go into an interactive session. Feel free to ask any questions. The modulator will take us through this session and we'll be answering some of the questions available and sharing knowledge. Just like I already see here, we have quite so many of my lecturers available online. They should be able to cover that and help us all through this. Thank you very much.
Thank you so much, Cosmas. It has been a wonderful presentation, and I welcome questions from the members. Though someone is saying, at Linda, is saying that how shall we have access to the presentation? So Linda, I think he's going to answer, but I think I've already answered everyone that that this on this forum or on this Zoom, all the members that have attended and need the presentation will have it via their emails, and some people have just sent in the emails. And at this moment, I'm waiting for questions so that you can raise up your hand. I don't know whether you all see where to raise up your hands.
Yes, Francis, maybe I've seen a question on prevention.
Yes.
A question from John Lawrence Muimba about the prevention of H. pylori. We looked at that in the very first slide, one of the very first slides we had, and we're looking at the lifestyles, the type of foods we eat, the sanitation. There are quite so many predisposing factors that we still need to have studied so to come up with a complete diagnosis. But not forgetting, for those that did not attend the first session of the presentation, 50% of the world population have H. pylori bacterium. And interestingly, 90% of the people with ulcers are infected with H. pylori. So I hope that answers your question.
Members, any others?
Hello. Yes. Can I talk?
Yes, please.
Hello. Are you getting? Yes. Defeat TB. And thank you, Joram, and the team. I wanted to see some on the demographics, especially on the age and sex of the patient. I mean, where is the effect more?
Just like we've said, we'll share this later on in the next presentations. We have some other presentations that will be coming on later on this same topic, because we have phases of the study. So we are still in the first phase. We were not able to capture the demographics, but we have them. We'll be able to share them later on.
About the cost effectiveness of doing the rapid test and the culture, if you have to have that implemented.
That's a very beautiful question. A question of whether to do the two tests. The challenge is apparently we cannot go direct onto the culture before we are sure of whether this is positive. That is what we've set as a standard in our study. But if at all we come up with the best method for culturing or for having this entire procedure done, then we should be able to explain this all through. But just like we mentioned before, sorry? Just like we mentioned before, we have individuals who have got bleeding ulcers. That's why we proceed and do tests such as the fecal occult blood test. And you'll find out for some that have a positive FOBT, the H. pylori is normally negative. So most likely there might be some interactions with the blood present in the stool, picking up the antigen on the strip. That's why we are thinking mainly we should have a first of all positive antigen test, that is the stool test, then proceed to the culture. I hope that answers your question, Ronald.
Yes, Jerome, that is okay. Then I mentioned that you're not certain whether the resistance was genome sequencing.
Ronald, you're breaking.
Always to have further stuff. Am I clear?
You're breaking. Hello?
Yes, Jerome, is that clear?
Yeah, I can hear you now.
I think my internet is. Yes, I was. The unknown about the or that would be causing resistance, especially. in complex strain. Is there access to genome sequencing within the country, or you could do within your resources to check for the bacteria sequencing?
That's a wonderful question, Ronald. But apparently facilities that are doing genome sequencing are really very low, even in Uganda as of now. But we hope this is going to be the third phase of our study. We hope to have comparative studies. So we'll have a comparison of our findings with PCR, with genome sequencing, such that we come up with a complete document to give it a go-ahead on stool cultures for H. pylori.
Jerome, we have a question from Yusuf.
Yes.
We have a question from Yusuf.
Yes, please. Which question is that?
Yeah, Mr. Jerome, thank you for the presentation.
You're welcome, Yusuf.
Yeah, I'm Yusuf from Lubaga Road Clinic.
Yes.
So I just have like 3 questions that I wanted to put forward for some clarification.
Yes, please.
According to the results that so far you have got,
Yeah.
can you confirm that pylori kit is no longer safe to be used to treat the H. pylori? That is question number 1. And another question is, during the management of H. pylori, how efficiently can we use the therapy that you've given us in the different trimesters during pregnancy? So those are my 2 questions that I had.
Thank you very much, Yusuf. Those are interesting questions. I don't want to go so deep into contraindications for pregnancy that I'll try to avoid it. But what I'm very sure of, these have been approved. The regimens that I mentioned are approved by CDC across trimesters. But now for the Pylo kit, we are still studying this. Just like we mentioned, we need to find out whether this is resistance, whether it is recrudescence, or it is a reinfection. So before you say we are pushing away this kit, you need to first of all know, in this kit, how many drugs do we have? But our biggest question or our biggest alarm is that we have clarithromycin in this kit. And of late, we have increasing clarithromycin resistant strains to H. pylori. So of course, if we find out that H. pylori resistant strains have increased in number and people are no longer responding to clarithromycin, then it would be best we put it out of the Pylo kit. I'm not nullifying the Pylo kit right now, but later on, maybe the results will help us to justify that, because we need data. You can't just come up with only 1 patient, only 24 patients, and then you're nullifying a kit that is being used worldwide. I hope that answers your questions, Yusuf.
Then we have Solomon. We have Solomon with his question also. Solomon?
Yes.
Yes, I can hear you. Thank you, Jerome.
Yes, Solomon. You're welcome.
Thank you, Jerome, for the presentation. I have a simple question here.
Yes.
You talked of the remedy, especially the tabs for treating this H. pylori, but I kindly ask you to answer. What if the first time I have a dose of omeprazole, and then the second time I'm given, maybe like you said, amoxicillin? How are these antibiotics grouped in strength, as in strength? Because today I may try this one, and another time we try another one. How are they compatible in strength? Thank you.
Thank you very much, Solomon, for that question. Maybe just a simple correction to make. Omeprazole is not an antibiotic. So omeprazole is just a PPI, a proton pump inhibitor, but I didn't want to go into depth of explaining that. So CDC thought it wise and WHO that we have a PPI and 2 antibiotics, at least 2 antibiotics combined during the treatment regimen of H. pylori to combat the resistance. Just like we mentioned in some slide, I don't remember which slide exactly that was, but that was the main reason for having a combination therapy. Yeah, it's here. It's here. So that's the reason why we have those 3. It's only 2 antibiotics and 1 proton pump inhibitor that is present in that kit. That is what we call the pylori kit or the pylo kit. It can contain omeprazole, esomeprazole, rabeprazole, whatever it might be. But our biggest concern is that it contains clarithromycin, of which we've received so many resistant strains. And it also it could contain maybe amoxicillin, metronidazole, tinidazole, whatever the case might be, or whatever the brand might be.
Then we have one from Titus Tembo. Titus, I hope I pronounced your name well. Titus. Titus. Titus, are you there?
Yes, I'm there.
Yes, please come up with your question.
Thank you, Jerome. My
Welcome.
contribution is on someone who about the pyro kit. Actually, when you talk about pyro, my contribution, I'm talking about the pyro kit and the clarithromycin.
Yeah.
The main reason why this bacteria is not responding to clarithromycin is that if you check in the pyro kit, the milligrams of clarithromycin is 250 milligrams of clarithromycin. And currently, as per the World Health Organization, because of the resistance they have been getting, a patient is supposed to take 1,000 milligrams a day.
Yes.
So in these kits currently, they are not working. What the main reason is the underdosing. 2 is that it is only 1 antibiotic that is working now, and this clarithromycin is around 80 to 85% in killing this bacteria. So I happen to work with a company which currently has two antibiotics that actually work on this bacteria. So the first one is they increased in the milligrams of clarithromycin. We now give 1,000 milligrams of clarithromycin. So they made 1 tablet, which is 1,000 milligrams, plus another antibiotic, which is also 86%, which is called nitazoxanide. Why they brought this nitazoxanide is because in these kits you find there is a metronidazole, other kits have tinidazole. Those antibiotics, the bacteria resists them completely. So in these kits you're going to find it's only clarithromycin that is trying to fight this bacteria. These other ones are not doing anything. So clarithromycin, if you have 1,000 milligrams, you have this other antibiotic called nitazoxanide. It is 500 milligrams. A patient takes them for 10 to 14 days. The bacteria goes.
Thank you very much for that contribution, Titus. I don't object it. I had it in mind as well, but of course, without data, there is no way we can defend this. That's why we decided to take this in phases, and we'll be able to present our findings of the concentration present in the kits, the different kits.
The good thing of your email, I will share with you some researches that we have.
It's okay. I'll be grateful.
All right. Thank you.
You're welcome. Thank you. Any other questions? Yes, Mr. Francis, do you have any other questions? Francis?
Hello.
Hello?
Hello.
Yes, Lucas.
Yes. Thank you, Jerome.
You're welcome.
I just have two questions.
Yes, please.
Unless I did not hear that well, did you consider amoxicillin? And
Yeah.
if not, why? Then
For the study?
Yes, for the study.
Yeah.
Then two,
Yes.
the breakpoints that we used for clarithromycin.
Yeah.
And then lastly, you talk about
Sorry,
the
once
social
again
demographic.
sorry,
The
Lucas,
break-
about the clarithromycin?
The breakpoints that you used for clarithromycin.
Yes.
Yes, and then lastly
Yes.
is about earlier on somebody asked about the social demographic characteristics. You said
Yeah.
they would be presented in another session.
Yes, please.
Now I wanted to know whether in interrogating the likely cause of this resistance, whether you also have included some other clinical factors
Yeah.
that could influence this resistance.
I understand.
Mm.
Thank you for those questions. I think I'll begin with that very last one. This was kind of a background study. We didn't, first of all, intend it to be a research, just like we mentioned before. And it's because of this case scenario that you see shared on the screen that we decided to go ahead and take this up. We had this patient who we had treated 3 times and they had no improvement. So we decided to do that. So we've not looked into the social demographies, how these people behave, did they take the medication completely? We hope that whatever we're going to pick, the suggestions we are going to pick from this presentation, we could be able to add them into the next phase of our study to have all those questions answered. So we'll include a questionnaire, Mr. Lucas, for that. And then the second question on the breakpoints of clarithromycin, we took anything below 12 to be resistant, anything between 12 to 14 to be intermediate, and anything above 14 to be sensitive. About amoxicillin, we did not include amoxicillin in the study because we had run out of stock of amoxicillin. And the time we were doing this study, it was during the lockdown. Just like you can see on the screen, we used amoxiclav, which is a combination of clavulanic acid and amoxicillin. We used it for only our very first patient, and that was the only last one we had left. So that's the reason why we did not include it. But now we're going to put together whatever the challenges we faced during this first phase of the study. We see how best we can improve and have many of these questions answered in the next phase. Of course, we also want to look at metronidazole or antinidazole to see how they really behave, because ideally, before we have any antibiotic rolled on for use, we should be able to have a DST available, drug susceptibility testing, before we can approve it for treatment into a specific human being, not just generally countrywide, worldwide, or nationwide. I hope that answers your questions, Mr. Lucas.
It's fine for now.
All right, thank you very much. Mr. Lucas is my lecturer for microbiology.
Oh.
Yeah.
Oh, that sounds good.
All right.
Nathan was saying something.
Yes.
While Jane Francis, did you answer Jane Francis, who said that how is it transmitted? I mean the H.pylori.
We talked about transmission. We talked about poor sanitation and drinking of contaminated water. But we still need to look at quite a number of researches to find out the rightful entry. But of course, the most susceptible entry is through the mouth. So it's through the oral route that anyone can catch H. pylori. And then we also looked at the risk factors such as maybe stress, the type of food you eat. That's in the first slide. We looked at smoking, alcoholism, type of food, stress, time meals are taken. Some people actually go days without eating. So those are some of the risk factors.
Jerome.
Yes, please.
So can I just say that after this period where people are locked down, that we are going to have many cases since going minus food is a risk factor.
Of course, we should be able to expect this, but just going alone without food might not cause you to have an ulcer. There are many other factors. It's just one of the predisposing factors. Of course, just like we looked at our very second slide after the first one, we said 50% of the world's population have H. pylori. But remember, most of them remain asymptomatic. Now, making matters worse, we go ahead and explain that 90% of these people with ulcers have them infected with H. pylori. So if at all you have an ulcer already open and you have the bacterium ready in your bloodstream or in your stomach or wherever it might be inside your body, then it should be able to infect and colonize that ulcer.
Hey.
Yeah.
Okay. And Godwin, is it Godwin Murungi? Godwin Murungi has something he was saying, and I think he can say it himself.
Yes, Godwin.
Godwin.
Yes, hello.
Godwin, you have
Hello,
something to say about the subjects.
Yes, considering that we are doing a study, I wanted to know how many people are in this study and whether that number would allow us to generalize for the other people out there.
Thank you very much, Godwin. We said this study is in phases. We started with 24 participants, and there is quite a lot of work that we've done with these 24 participants that we might not be able to disclose right now. But later on in the second phase, one of our first thing that we are planning to do, after validating this procedure, we hope that we should be able to increase the numbers. Because right now, in our laboratory, we see over 2,000 patients, close to 3,000 patients a month. And out of these, you'll find out you have close to 200 patients or 100 plus infected with H. pylori. That is having a positive antigen test, a stool antigen test. So we hope, if at all we can have all these numbers included into this study, we should be able to have better data to come and explain all this to you. I hope that answers you, Godwin.
Thank you very much.
All right, you're welcome.
Then
Thank you. Yes?
We have from Jane Francis.
Yes, Jane Francis.
Jane Francis, are you there? Jane Francis? I don't know whether she's there or not, but I'm seeing her on. Jen?
Hello.
Jen, are you on? Jen, your phone is bringing back an echo. Jerome? Jerome, I can't hear you. Jane Francis.
Yes, please.
Jane Francis, we are waiting for your comment. Or
I think we lost her.
have we lost her? No, Jane Francis is on. Jane Francis.
Maybe in the meantime we could be having another
other people coming in to ask their questions. Members, do we have any others?
So I think if we do not have any other questions, I want to thank all of you for having attended this meeting. It's really been a wonderful session of sharing with you. I want to thank you for all your contributions. We look forward to having another session still on the same topic, but now discussing other findings of this study. Just like we've said, this study is going to go through phases. This was phase 1, which is more of just a sensitization study and getting to know where we are and what our stand is. We'll have a second phase, third phase, possibly a fourth phase, and we should be able to share our results to what we'll have obtained from the study. Otherwise, I want to thank you so much for your time, and I remain Oga Cosmas, the laboratory manager, Chisubi Hospital Diagnostic Laboratories.
Oh, thank you so much, Jerome. And I wish to thank all the members. I wish to thank you all members for your attention and all those who have been giving in their contributions. Yeah, about the session.
Francis?
Yes, please.
It feels like Jane Francis is speaking.
Hey. Jane Francis?
Hello.
Yes, please.
Hello.
Can you hear me? Thank you for the presentation. My question was whether the ulcers by the H.pylori can heal, because I was diagnosed with ulcers and given the kit did not heal, and later on got some other antibiotics from the same hospital. And I still saying
Jane Francis, I can't really hear you. I can't hear you so well.
I was saying,
Yes.
my question is, do
Yes.
heal?
Yeah.
Do the outside heal?
Yes. Oh,
Jerome?
I think we can have Jane Francis type the question
Jane
as we
Francis
answer
is asking.
Ibrahim.
Jerome?
Yes.
Jane Francis
Yes, please.
is asking that do the ulcers heal?
Oh. Ulcers can heal. That is the first thing. An ulcer is just a wound. So if you're asking whether a wound can heal, yes, a wound can heal.
Yeah, but using
the biggest question is
the pyro kit.
We are still studying so many factors that could be influencing the failure in treatment of the current regimens. And we do not want to commit ourselves to say that the pyro kit is defective. We want to change it right now. We are not doing any of that with this study. Later on, maybe with the findings we'll obtain, we should be able to come up with a clear explanation. But what I've seen with many of the physicians available, even with our hospital, they've received so many people that have not responded to the pyro kit. and they've decided to give separate triple therapy for all these individuals. They've been given a PPI separately and the other 2 antibiotics separately, such that we run away from the 250 milligrams, so we can have 500 milligrams at least on a daily basis, which we think might be one of the contributing factors to resistance or failure in treatment. So the ulcers can heal, that's the first thing, if correctly managed or if given the right full treatment. I hope that answers Jane Francis.
Did you hear this also, Jerome, that you needed to throw more light on how to deal with the asymptomatic patients with the H. pylori?
Oh.
That is Nathan.
Those are quite separate studies that need to be looked at. We need to look at, first of all, if at all the asymptomatic individuals are affected anyway, because you can't treat anyone who is not affected. So if the asymptomatic individuals are not affected and there is no problem that will be caused by the H. pylori, then we hope they might not need treatment. But if at all H. pylori is not one of the normal flora in the gut, then it should be eradicated. But still, with the findings we obtain in the different phases of this study, we should be able to come up with the rightful answer for that. Thank you very much.
Hey, and you can't go away also without answering Annette Nakawesa.
Yes.
Who is also saying that why is it that people with the bacteria for years cannot get the ulcers?
People with the bacteria for years?
Yes.
I've not heard of those that have bacteria for years, but well, if at all they have the bacteria and they've been having the bacteria for years, maybe it's because they do not have the ulcer yet in the body. So first of all, you need to have the organism present in your stomach, in your duodenum, or wherever it might be in the gut. And then second of all, you should have an ulcer. So it will either be the organism, the H. pylori bacterium, to form the ulcer, or it will find an ulcer ready in the stomach so it can have it colonized. We've had individuals that have got gastric cancers, gastric carcinomas. Some others have got very challenging syndromes such as the Zollinger-Ellison syndrome, where we have the stomach secreting acid simultaneously even without food. Those are people who are really at risk of H. pylori, and they normally get the H. pylori. But having the bacterium for years and then you do not have the infection, you remain asymptomatic. I've not seen it, but I have no answer for that. We need to first study it and find out which individuals those really are. Then maybe we need to find out if they even have the infection or if they have the bacteria in their bloodstream.
Oh, thanks so much, Jerome, for the presentation and for answering our queries and questions.
Yes, you're welcome.
There was Mr. Kabazi Jonathan who was saying that next time maybe we also send these invitations to their emails. Now that we have them, I think we shall do that.
It's okay.
I thank you, members, for the attention and for attending. And those who have not been able to join us on time, because I can see others are just trying to join us right now. I can also allow you in, but maybe just to wave to your friends. And I'm requesting members at this moment to share or to switch on your videos so that we can just wave to Jerome and we say hi to him, and then we can call it a day. Yeah, members can switch on your videos so that you wave to him and say hi.
Hi.
Thank you.
Hello.
Hello.
Thanks for the presentation.
You're welcome. Thank you.
Thank you for the presentation.
Oh, welcome.
Hi, Baba.
Hi.
Hi, Baba. Yeah.
Thank you for the presentation.
You're welcome.
Otherwise, members, take care of yourself, and please make sure the curfew does.
No, yes, you are just going to.
We need to see you tomorrow or any other day. Stay safe.
Francis.
Wash your hands. That distance. And
Yes, Francis.
use all. And you can to make sure that you are safe. Otherwise, thank you so much, and I think everyone now.
Obanga obawo nga bubaawo noli yennyini yaddala awo zambe oba akola ku vidiyo